Now we're going to start. We're going to have a discussion. First on this issue of confidentiality, please welcome to the stage Paul Samuels, President of the Legal Action Center, and Joe Parks, Distinguished Research Professor of Science at University of Missouri in St. Louis. Paul Samuels and Joe Parks. Come on out, guys. So this issue of 42, how many of you know what 42 CFR is? This is new for me. Wow, they all go up. If your hands didn't go up, just ask your neighbor. So let me let me just start out with you, Paul. Can you just sort of set the stage for a moment for us and sort of tell us what the stakes are? Because right now we're having a big debate about the broad issue of whether patients should be largely in control of their own privacy within the healthcare system and be assured that they're not going to pay a price or consequence for that, or with my friend Joe Parks, who basically says they're going to suffer if we don't have greater fungibility of that information among professionals, if I have that right. So, but just set the frame from your perspective.
Sure. Well, privacy in healthcare is a balancing act, no matter how you look at it. On the one hand, it's important to maintain patient privacy for a lot of reasons that we'll talk about. But also it's important for information to be communicated, for coordinated care, but also for a lot of other reasons to keep families involved when that's appropriate. So it is a balancing act.
But my understanding with some of this is that privacy goes so far that the families can be left on the sidewalk.
That can happen. And one of the basic principles, as you referred to, is patients having control of their records and having control of the information. I think it's important for setting the framework to understand that the confidentiality law for substance use records was the first federal confidentiality law ever passed. And that was several decades before HIPPA. And the reason was that there was a great deal of risk then, and there still is, for people with substance use histories of what could happen if their records could get out. And it's important to understand it's different in some important respects for people with substance use disorders. To give just a couple quick examples of that, diabetes healthcare professionals don't get subpoenas on a regular basis from patients' former partners to use their history of diabetes against them in a custody battle or a divorce proceeding. And the same thing goes on. People with hypertension don't have to worry that when their records are disclosed to insurers for reimbursement, that they could be forever prevented from getting life insurance or even lose their job if their employer is providing the insurance. And most dangerous of all, cancer clinics, stroke clinics don't have law enforcement officials parked outside in front and coming in with search warrants trying to arrest and prosecute patients.
So you're basically arguing that society is still so warped, that there's so much stigma, that there's so much potential consequence for people that it's better to leave the walls up.
That's a big part of it. Another
you
part of it.
You could just say yes.
Well, yes. Yes, but there's another big part of it too, which is that when it comes to substance abuse treatment, we're talking about people, a large percentage of whom have committed illegal activity, and for whom their records contain information that could prove criminal activity. So that's a whole different element that is not present for other healthcare records.
Joe, take us on a journey on where that you believe very vociferously and vigorously that perspective is very old hat. So take us into the new era.
So let me start with my agreement, then I'll get real controversial.
Okay.
I agree entirely with 42 CFR provision. You can't use healthcare information for prosecution. I would not change that in a moment. I would be upset if it were changed. I can live with 42 CFR saying that you must have consent to release anything.
Get it a little closer to you.
I can live with 42 CFR saying we must get patient consent to share information, which does go beyond HIPAA. What I don't think CF40 needs is it takes away a person's right to release their own health care. If I have PTSD, which has stigma, if I have epilepsy, which has consequences on if I can drive and if I get what kind of job, I can still decide to say, yes, share my information with any healthcare provider. No, do not limit the time on that consent. And yes, other healthcare providers can redisclose that so I can get high quality coordinated care. Under 42 CFR, I can't do that. It has to be time limited, so I have to think ahead and decide and redo that release. It can only be for certain specific purposes. I can't say tell it all. I can't decide ahead of time what will be needed. So 42 CFR discriminates against people with substance use disorder by not allowing them to release information in a broad, extensive way that they might wish to.
Let me ask you a slight, put this in human terms for me for a minute, because in preparation for today and also talking to a number of people out there, I know there are a myriad of stories. Everybody has a story, and they have a personal connection to this subject, to this conference, and so there's a lot of pain, process, trying to think these things through. And as my understanding, that at least in the journalistic profession, we have lots of stories on doctors and practitioners who don't share because of fear of liability, because of HIPAA, because of 42 CFR, and I'm interested in what the human cost to that is.
Well, I think it depends on where you sit. It depends on whose human experience you see. Paul's a lawyer, so he's very familiar with the legal consequences, the social legal consequences. I'm a physician. I see people come into the ER on prescription medication overdoses because the doctor prescribing methadone didn't know they were already getting methadone someplace else. The high 30% of all overdoses are methadone. And in some areas you're not supposed to share that. It's the balance of social legal harm versus clinical mortal harm. What's more important,
so we're in
living or having a job?
2016. Let me ask you both. Isn't there a way to square both? Not that I want to necessarily solve this battle between the two of you. We could keep it going for a long time, more than 8 minutes and 49 seconds. But I'm interested in whether or not, given technology, given where can't we create a cleared path where professionals have access to information that wouldn't necessarily leak out? Isn't that doable?
So absolutely, and I think let me lead into my answer to that by starting with what I agree with my friend Joe, a number of things that he said, which is important for us to do what we can, especially in this new world of electronic records and integrated networks, to get information to be able to flow from substance use providers to other healthcare providers in whatever ways will benefit the patient. But it's important that it be benefiting the patient. Now, fortunately, in answering your question, yes, we can, and a great big thanks and kudos to SAMHSA, because they just came out with proposed changes to the regulations that we think take us a long way. In fact, probably maybe as far as we can go to strike that right balance, because it makes these proposed regulations make it much easier for people still to sign consent forms, because there needs to be consent, as Joe said, and I agree, but it makes it much easier for consents to be developed and signed so that information can go into integrated networks and also be redisclosed to any treating providers in those networks and also in health information exchanges. We think that does square the circle, and we strongly support that approach.
Joe, is that enough?
I think it's a great step forward. I applaud
So
SAMHSA.
it's not enough.
It's not enough. It is not enough. Thank you for helping me with that. Yeah. And we can go further. The underlying statute to 42 CFR is only 474 words long. It's amazingly short. And the only thing it requires that is more strict than HIPAA is that you have to get a consent. Under HIPAA, you can share information absent consent, and you can't use it for prosecution. All that other stuff, time limited, specific purpose, can't redisclose, that exceeds the statutory authority. It's not enough. Because all of you operate agencies, if these are time limited, are you going to have a tickler file when each one of those permissions expires? And are you going to put staff to find that person to say, hey, do you want to extend that? Do you need to extend that permission because you still want to get coordinated care? I don't think so. I don't think you have the money. I don't think you'll find the people.
Paul, I want to ask you one question. I was reading up on you, and you wrote something very interesting. I want to ask actually, it was Joe that was quoted. I'm going to ask Paul to comment. But Joe, you were commenting, it says, as long as behavioral health is treated separately from other medical specialties, it will never be equal. And it's an interesting frame, and particularly very important for every single person in this room, that when we think about law, you started out talking about diabetes, so I'm interested in whether or not, through good intention, both of you care a great deal about patients and the course they're going on. But as you try and preserve these walls, are you trying to keep the behavioral health profession sort of set aside and not taken as seriously as other ailments?
Well, I certainly think it's critically important that mental health and substance use disorders be given the place that they deserve in our healthcare system, which is equality. And we have not had that. We still don't have it. We finally have it embedded in law, in the parity law, and now in the Affordable Care Act. But we have to move that from formulation in law to reality. But at the same time, it's important to recognize there's a lot of discrimination, not just stigma, but discrimination against people. There's a lot of people with substance use issues who do not get good health care because many of the healthcare providers don't treat people the way they should. They have the same prejudices. They don't get trained in medical school. They don't treat patients with respect. So there's a lot of problems there. We still need to maintain protections. But I would also argue that we don't have enough confidentiality in any healthcare records. HIPAA is part of the problem. There's a lot of records that leak out because of HIPAA, as well as the way that records can get hacked into. So I would say it's important that we protect our patients first and foremost and protect their rights. But let me just say one thing too, that I do agree with Joe about the importance of making the consent process work in this environment. But we really think that some of the recent rulings that SAMHSA has made, plus the new proposed regulations, solve the issues that Joe is concerned with. Just to give one example, consent does not just have to be limited in time. Someone can sign a consent form where it expires upon the death of the patient, which should be long enough to deal with for healthcare records. So, and we think it is long enough. So we'd be happy, to look forward to working with Joe.
Oddest laugh line I've heard, but
hey,
we
lawyers get them where we can. It's usually at our expense.
Joe?
I'll tell you the other thing that 42 CFR does. It actually decreases access to care, and it makes other healthcare providers believe that substance use disorder treatment is ineffective. It is anti-advertising. The rest of healthcare knows about all our treatment failures. They see them in the ER, they see them in the clinics intoxicated. They don't know about our successes. They don't see the other 20 people in their practice who got treatment successfully 3 years ago, 5 years ago, 10 years ago, and are sober and doing well. So they think our treatments don't work. And they think we're obstinate because we do not reply to the record requests like the rest of healthcare. This is a cultural competency issue. It's the height of rudeness in the rest of medicine not to automatically send a report when somebody sends you a referral. We hide our success under, and they don't know how to treat it because in medicine, it's see one, do one, teach one. Doctors learn by watching each other. After I was in my clinic treating bipolar disorder for 3 years, the primary care physicians were prescribing lithium, Depakote, and antipsychotics just like me. But we hide from them how naltrexone, buprenorphine, and acamprosate are prescribed because that's secret. So they never learn it because they can't see it and they don't believe it works because they only hear about the failures.
Let me ask you, in the last few minutes,
go ahead.
Paul?
Let me just quickly strongly agree with what Joe's concern. I totally
really strongly.
Strongly agree.
Yeah.
We need to do a much better job of connecting our systems, and that includes we need to do a much better job of educating substance use providers about that when they should be disclosing and that in fact they can disclose. But that's not a problem with 42 CFR Part 2. It's a problem with understanding what the rules are and how disclosures can be made while still protecting patients.
We've been trying to get our staff and ourselves to understand it since 1987. How much longer you want to try to see if we can get it right? How's that working for you, Paul?
I am an eternal
motivational interviewing.
I am an eternal optimist about the abilities of our field, and I really think with these new proposed regulations, it will make it much easier. And you know what? We've overcome bigger challenges than this.
You've got 30 seconds each. I'm going to make you each all-powerful. But one of the interesting things, and I don't know, maybe this is a dangerous question for me to ask, but 42 CFR, and I've read a lot about HIPAA that we didn't have time to get into, are they protecting laziness? Are they protecting lack of change? When you look at the fuzziness of diagnosis and the desire to want to sort of stay away from some problems that somebody, you have this problem, which I know you're trying to basically deal with. But if you were to be all powerful, what would you do? And you've got 30 seconds.
I would finalize the SAMHSA regulations. you know,
That's
there'll be
all?
some technical,
All powerful?
and then
That's
and
all
then-
you'd do?
And then what we would do is we would enforce those rules. And really, there's the global issue that we need to enforce parity, ACA. We need to make substance use and mental health the equal partners in the healthcare system that they should be. And when that happens, there'll be a lot more opportunity to get people the care they need.
Joe Parks.
I'd probably uncreate opiates entirely, but I have to think twice about alcohol. But if I weren't quite that powerful, I would have a 42 CFR law that went no further than the statute. You could not use it for prosecution, and you needed consent. That would be simple. Separate is always complicated. Separate is never equal. We're discriminating against the people we serve.
Great exchange. I just want to say thank you. I want to tell you something special about these two men. Joe Parks, on his own time when he's not at conferences like this, is a great Argentinian tango dancer. And Paul Samuels plays tennis, but he was inspired by his grandpa, who won the 1912 New York City all high school tennis championships. I think that's a super cool story. So give it up for Paul Samuels and Joe Parks. Thank you both for coming. Tango.